Hello, everyone, and welcome back. Today, I'm talking with Dr. Rebecca Patton, a pelvic floor physical therapist and the founder of Patton Pelvic Health. Rebecca is actually local to me here in Arizona, which is really cool. And I was so excited to have her on because the work she does overlaps so closely with the digestive issues we talk about on this podcast. In today's episode, we get into a side of constipation, motility problems, and recurring SIBO that is so often overlooked. Pelvic floor dysfunction, abdominal tension, and scar tissue or adhesions from previous surgeries. Rebecca explains how all of these things can affect the way the digestive system moves, how they're evaluated, and what pelvic floor and visceral physical therapy can actually do to help. I learned so much from this conversation, and I think you will too. So let's get into it. All right, guys, welcome back. Today I am with Rebecca Patton, and she is a pelvic floor physical therapist. And Rebecca, welcome.
Hi, thank you for having me.
Yeah, tell us what you do and what got you interested in physical therapy and then pelvic floor physical therapy, because that's a really interesting path, I think.
I think so too. It used to be more unique and now it's becoming a little bit more popular. So I appreciate the acknowledgement and excitement around pelvic health recently that I've seen. Yeah, so I'm a pelvic floor physical therapist, which is a physical therapist by trade. I mean, the undergrad and the graduate teaching is physical therapy. And then the additional specialization is within mostly pelvic floor dysfunction, which will overlap into any type of bowel and bladder incontinence, sexual dysfunction, chronic pelvic pain. And so we are treating the musculoskeletal system, nerve, and body coordination, rehab, and then integrating the pelvic floor with functional and recreational activities, depending on what the patient's goals are. And I don't think that I was interested in pelvic floor initially when I went into PT school. I was much more thinking about athletes and I was thinking about dancers. I was thinking about gymnasts a lot because those were my recreational activities. And then I heard a bit about pelvic floor, but it was a very hush hush discussion. It was like, wait, people do this. I need to know more. No one talked about it. And I really didn't like not understanding. And anytime I found there was like a little gap in research or education, my brain just deviated that direction. So I asked for a clinical rotation and almost immediately fell in love and was like, this is what I want to specialize in. Mostly because it's not addressed enough or talked about. And now we know how prevalent having at some point pelvic floor symptoms, including leaking, is going to happen in your lifetime, constipation. These issues are really common. They're also highly dismissed, and people don't have the outlet of resources to address these issues necessarily. And so a lot of people live with these things for a very long time before they come in for help.
Yeah, absolutely. And that's why I like to build partnerships with pelvic floor physical therapists. And because I know, like you said, it's not something a lot of people have ever even heard of. The traditional path would be, right, you're having digestive symptoms, maybe you're having constipation and bloating. You go to your primary doctor, they refer you to your gastroenterologist. And then the gastroenterologist may not even bring it up, right? Pelvic floor at all whatsoever. Sometimes they do, but I don't think it's the standard path. And yet these people, like what we see with the functional health, kind of microbiome, functional digestive wellness area, we also see people struggling for years without ever looking at things like the microbiome, the health of the gut lining, the health and function of the gut. And so that's where I see our work, what we do here and your work, so interchangeable. And really, sometimes we need both. We can't separate because what we do, focusing on digestive sufficiency, the microbiome, inflammation, it can only take people so far. And then if there's structural issues, and that's what I'd love to talk about today, structural issues that are playing into, contributing to those symptoms, what could be causing that, what can be done to assess it, and then what can be done to treat it.
Mm-hmm. These are great connections.
So I think if we think about who's listening and what they're struggling with, and starting with the symptoms, maybe we can take the path from there. So what we see a lot in our practice, we see a lot of constipation, bloating, motility issues. And so in our work, that can be caused by things like methane SIBO, inadequate bile flow, motility problems. But where would pelvic floor play into that clinical picture?
Yeah, I think just the definition of, oh, someone's a pelvic floor therapist. My definition is someone specializing in pelvic health needs to work on specializing in abdominal pelvic health. And the easiest way to explain how the musculoskeletal system impacts these digestive issues is that everything in your abdomen is a sump pump, meaning all the muscles that you can control, the diaphragm, the abdominal wall, the pelvic floor underneath, your spine, and the muscles around your spine, all of that creates a giant container and a pressure system. And for most of my patients that are constipated and have SIBO, rightly so, it's painful, and your body, when it wants to protect itself, creates tension. And so muscles will stop being used in their fullest range of motion. And that essentially has a compounding, like, unfortunate effect of slowing down motility even more. So now we're kind of thinking, what are the abdominal wall muscles doing? One of the biggest things I'll see is the internal oblique muscles, which pull your rib cage in and downward, can be super tense sometimes. And I think of that as kind of cutting off the movement around the transverse colon and around the stomach. And so really any cascade can happen in that chain. You can have pressure system tension in all of the things. You can have some that are overactive and some that are underactive, and we need to increase connective tissue and strength. And then other times we have muscles that are doing way too much work all of the time, and they need to learn how to do less work. When we talk about breathing, this is the first input that we'll hit on in pelvic floor rehab, which is how does your pelvic floor and then your diaphragm coordinate and connect with each other? And how do they create that moving sump pump? And then people will leave and then come back and say, oh, I've been breathing wrong my whole life. And I usually try to tell people it's not that you've been breathing wrong. You've lost some ability to breathe into different compartments. And there is not one right way to breathe all the time, but you are going to shift your breathing all day. Like you're going to shift your posture, like you're going to move your joints. And we all have a tendency to shift into a certain posture through the day. And it's just really important to learn the way that you shift your posture so that you can also rehab and shift out of it. And really with constipation and bloating, it's the pressure that these inflammatory conditions are causing that hurts. And then unknowingly, the body protects itself by creating more restriction. So as a PT, we could be looking at the pelvic floor, the diaphragm, which is rib cage. We could be looking at the abdominal wall, and then we should be assessing the spine and the hips, because any of these can be big drivers. And I'll always tell people there isn't one data point that is the most important piece. It's the collage of how your body's moving together. But no one should be saying like, oh, your hip flexor weakness is the cause, right? It's not that simple. It's this collective movement repetitively of the body.
So what I hear you saying is your muscles surrounding the intestines, which we never think about. I feel like we do a little bit and then you do a lot, but I don't think many people do, even when they're thinking about gut health. So the muscles surrounding the intestines brace against the pain that's coming from the intestines. And that can happen in all areas, right? Surrounding. And that's a really an interesting point, because even when we think about pelvic floor, I mean, that's talking about the floor. That's not talking about the abdominal muscles, right? Or the diaphragm, but it's all related. So you're saying the whole thing. And then you mentioned the spine and hips, but those are not muscles. Those are bones, right?
Really how the muscles move then over time impacts the joint. Is the joint getting blood flow? Is the joint getting tissue mobilization? Is it getting tension input through a big range of motion? And if joints aren't getting that, then they will be restricted to a smaller range of motion. And so that can show up by someone losing the ability to flex or extend their spine or twist. One of the things I look at all the time is the ability to rotate, because where the diaphragm attaches into the thoracic spine drives a lot of rotation. And that means your rib cage and your pelvis should be able to move in opposing directions. And a lot of my patients have lost some of that range of motion. Again, the system is protecting itself and it's doing a really good job of it. And there's a time frame, and this is what you highlighted before, where I can't necessarily fix that whole system in pelvic floor rehab either, because if someone's gut health is being constantly irritated, right, then we're going to be futile in the rehab strategies that we're trying to do. And vice versa, if someone is rehabbing their gut, but then never moving in a new way, they can't teach their body how to not create that protective response again. So I always think of these computer that wasn't like a home computer. It was like the OG computer. It was like, it took up a whole wall and there's all these dial switches. And really the musculoskeletal system, there's a bunch of dials that you can turn up or turn down to help with pain and movement.
Okay. Yeah, that's a really good visual. Yeah, and what you're saying is that's why I think working synergistically together is so important. And we often refer our patients out to be evaluated for these sorts of structural issues, because it goes both ways. As a chicken and egg scenario. And just like if we work on the microbiome, let's say somebody has a methane overgrowth of archaea and we clear it, but their muscles are still bracing, or maybe they have true pelvic floor dyssynergia or something like that. They're still not able to get to that place where they're eliminating stool optimally. And then vice versa. You're saying that it can be hard if maybe they have a lot of inflammation in the gut and that's persisting. And so they're continuing to have that pain. You can work with them, but they're still going to be reacting to it, right?
Right, absolutely. There is a fine line and there's no one set protocol, which I think is really nice for patients to hear, because there's going to be essentially an ebb and flow. And helping people, especially when they're in a flare up, would be a big piece of the puzzle. So I want to make sure that people have like resources and navigation, especially through any gut health flare up, so that as quick as possible, we can start to help that system feel safe again to move and to know that it's okay to move, and what ways is it okay to move. And then you highlighted something which you really talked about, how the pelvic floor is the outlet for constipation. And one type of constipation being outlet obstruction, which is really when your pelvic floor is too tense and doesn't have the range of motion to drop and expand backwards. And those patients will feel like they can't eliminate stool well, and they constantly have a feeling that they could go more, or when they push out, it hurts. Or this is also where we talk about recurring fissures or tears and hemorrhoids. And then now every time that happens, there's like a flare up and a protection of that response too. So a lot of the symptoms could be, hey, we got motility to work better. Yay. And then now we've got to deal with like making sure that you can sit on the toilet efficiently. And that comes down to so many things: breathing, positioning of your hips and your legs, your abdominal wall, and then how you're really creating downward pressure.
Right. So we're talking about the abdominal muscles, and then we're also talking about tension versus relaxation and the coordination between it, right?
Yeah. And we hear a lot more, I think, about strengthening the pelvic floor. It's got to be strong. It's got to be strong. But like any other exercise, the dosing that you give someone for how many repetitions that they do is really important. And if someone is not actually doing a pelvic floor evaluation and we're playing guessing games with the muscle and what it's doing. So this is me saying an actual referral to a pelvic floor therapist that does internal palpation and evaluation of the pelvic floor is really important, because we don't want to be playing guessing games with what we think someone's pelvic floor is doing. the gold standard. And this is probably my biggest passion, is that as pelvic floor therapists, we hold ourselves to only calling ourselves pelvic floor therapists if we're doing those types of evaluations.
Okay. Because I know clinically they'll use like a balloon, right? Is that what you're talking about, or is it similar only using your fingers?
Oh, it's very similar. When people mention biofeedback, that is for the patient to understand what their body is doing, but that can happen in a lot of different ways. Certainly, a balloon test can be both evaluation and treatment, but clinically, I really feel like a digital exam is my best tool because I get the most information out of that. After that, it's really how does the patient get the best information? And so sometimes that could be a machine measuring their muscle function while they look at the machine move. And sometimes that can be a balloon expulsion test and treatment for like, hey, awareness of that pressure system in the rectum. And then when would they push it out? And then how would their muscle feel with that? And other times it's just a digital exam where we put pressure on the muscle and the patient can coordinate their breathing and their attempt with that. So there are layers to that, but it will be different depending on each patient.
Okay, so just if we break that down into 101 for someone who doesn't even know what we're talking about when, let's say, you're having a bowel movement, there are muscles that are pushing, so they're contracting, while other muscles at the same time have to relax, right? So there's testing that can be done to figure out where's pressure happening. So let's say that while you have certain muscles pushing, then maybe the sphincter that's supposed to relax is actually tensing up. So nothing's happening. And that's exactly what can happen sometimes, right? So the testing we're talking about is figuring that out, right?
Mm-hmm.
And you're saying with your fingers, and I know that they'll do the balloon expulsion to see if you're able to expel a balloon.
Yes, exactly. Yes, I think that this testing is so important for us to be doing because it's a big piece of the puzzle. And so, one of the biggest muscles that we're talking about with this is the puborectalis muscle. And it's basically this muscle that wraps right around the end of the rectum and it attaches up into the pubic bone. So, if my finger is the rectal canal and my hand is the pelvic floor, that first muscle right here would be the puborectalis. That's what we press on. We press on these deeper pelvic floor muscles that create a hammock, and we get a sense of whether when someone bears down, is that good range of motion or does that muscle tense up? And very often it's what you described, which is we use the word dyssynergic a lot, which is when someone tries to push down, it tenses up instead. And then we do neuromuscular or body to brain connection. And that also highlights that this is very different than other types of rehab. You get to, when you're thinking about your elbow or your shoulder, you really get to look in a mirror and you get to bicep curl. You get to see that muscle engage. And typically for this evaluation, I have patients mostly lay on their side and in a comfortable position where they get their knees supported and we can really focus on just their pelvic floor and their breathing, but they do not get to visualize their pelvic floor move in this evaluation. And so that's where biofeedback and the balloon expulsion, these other things, helps with that brain to body connection. And that's what makes pelvic floor rehab a little bit different than others is you lose that visual component. Occasionally you can do visualizations, but the biofeedback is what is that visual.
Which makes it a little more objective for the patient to perceive. And what do you mean when you say biofeedback? Can you explain that?
Yes, absolutely. There's internal and external biofeedback. The external are sensors around the pelvic floor. So we would go right next to and just off of the anal sphincter to pick up that deeper pelvic floor muscle. These are typically just like little sticky pads, and that would be the external version. And it's measuring the muscle activity. It's not doing any type of electrical input. You don't feel shock or tingling or anything. It's just measuring. It's measuring the muscle activity. And then there's a monitor or a sensor or a handheld device that someone can watch to see if their muscle is staying tense or relaxing.
Okay, great. So with the abdominal tension issue or just diaphragm, abdominal muscular tension issue we were talking about earlier, that can happen to anyone, right? Because it's related to pressure, it's related to pain, it's related to how we hold ourselves, maybe posture, tension. Are there certain people who are more likely to have certain types of dysfunction? For example, what we were just talking about with pelvic floor dyssynergia. Are there certain people that are more at risk for things like that?
That's a really good question.
I'm thinking along the lines of like if you've had childbirth or any sort of surgery or anything like that, it might send some alarm bells off if somebody's listening and fits that description.
Really, what you just mentioned, for sure, childbirth, anything that changes how you would connect with that entire pressure system, which obviously pregnancy would shift that in a big way. And then it has to shift back to something new postpartum in a big way. So that would be a major time where I would hope that everyone, and we don't have access for everyone to get that resource, but it should be standard of care to not wait for people to have symptoms postpartum. It should be like that you had a baby and you get to have rehab during pregnancy, you get to have rehab after pregnancy, catch things before they become an issue. I would see this after any type of pelvic surgery. I'm thinking hysterectomy, a bladder lift, or a rectal prolapse repair. Actually, after someone has their prostate removed, this can happen too. But I mean, the extension of that, that's pretty, I would say, standard that people might think about rehab for those things. Maybe not. I'm in that bubble. But now I'm extending it to really any abdominal surgery. During abdominal laparoscopic surgeries, they typically will inflate and add in pressure for air to have good visualization. So now we're talking about bowel surgeries and we're talking about ostomies and endometriosis excision, fibroids. I mean, the list is really endless. I worked on a rehab floor in the hospital on a GI floor. And so that was actually the start of my pre-pelvic PT career. I saw a lot of patients with open abdominal wounds getting up for the first time and trying to learn how to move and get out of bed. And I saw all of these abdominal surgeries for so many different things. And I thought every single one of this is really eventually abdominal pelvic PT rehab long term, hopefully. But we don't think of that in our medical system. People get shoulder surgeries, they get a year of rehab. I mean, hopefully, or we're telling them this might take a year before you have full function and range of motion, coordination, strength to use your shoulder in the way that you used to use your shoulder. Same thing with Achilles tendon rupture. People know that those rehabs are going to take a long time, but for abdominal surgeries, we don't tell people that. I think I still see this like 6 weeks and you're good kind of information. And that's not what this looks like.
Wow, that's a huge paradigm shift and it makes so much sense. And so what you're talking about, because I did want to talk about this too, is are you getting into the visceral category where we're talking about just even connective tissue and adhesions and things like that? Or are you talking about even just the surgery effect on the abdominal kind of musculature or just all of it?
Both of the things that you mentioned. Yeah, both of the things that you mentioned. It's an abdominal surgery means when you say visceral, organs physically need to have mobility. And you can have things that now after a surgery, like let's just put one that I see often, the sigmoid colon in that lower left part of the pelvis comes up against the side wall of the iliacus muscle. And we need space between those two structures to move. And imagining someone who might be constipated, that curvature of the sigmoid colon, that's where things might slow down. And that's where things might start to get backed up and tell the rest of the system, like, hey, don't move because we're stuck here right now. So now, yeah, we're talking about that visceral component, the mobility of organs, which people don't realize. The connective tissue is flexible, it's treatable, it's rehabable. And then just the generalness of recovering strength after a general surgery where you've been told that there's like a 6-week period where you really can't exercise and move in a certain way. Like maybe you're allowed to do walking in your daily activities, but that is deconditioning for most people.
So this is huge because if you're listening and you deal with chronic constipation and your doctor's told you have severe or even just moderate motility issues, here's your Miralax or here's your Linzess, and that's your treatment and that's it. What we're saying is if you have an abdominal surgery in your history, and those are so common because think about it, appendix removal, gallbladder removal, C-section, hysterectomy, right? The list goes on. These are not uncommon surgeries at all. And you could have connective tissue that is adhering from the surgical site to your intestines and affecting the motility. This is also a root cause of SIBO that's highly under-recognized. And I'll work with patients, and we're always in our practice talking about what caused it, because if we don't talk about that and explore that and address it, SIBO just comes right back and it's so frustrating and it's not a good situation. So we're always talking about that. And I'll have women tell me, well, yeah, I've had a hysterectomy. I had my gallbladder removed, but do you really think that couldn't be related? And I say, absolutely. It's like a big firework going off in the sky. That's huge. Or a red flag. We want to recognize that and definitely at least go to somebody to have it evaluated, somebody like you. And when I first spoke with you, I didn't know that, I just didn't realize that a pelvic floor therapist would also do visceral work, and probably all of them don't, but you do. Mm-hmm. And I was super excited to hear that. So can you tell us more about, we've talked a little bit, we'll talk more about pelvic floor work, but what can actually be done to help with these visceral issues? So the difference is, like, I guess, muscular structure versus connective tissue structure. Mm-hmm. Muscular structure that may be directly affecting the muscles involved in motility, moving the bowels, and then versus, I guess, connective tissue, which is also affecting motility because the connective tissue connects to the intestines. It can change their structure. It can cause little kinks and little pockets and little corners that wouldn't necessarily be there. And that's how SIBO can be allowed to build up. Bacteria and food that would normally flow smoothly can kind of get caught in those areas. But does it also affect, like you're talking about the colon, so would those adhesions also affect movement? Makes sense that they would.
Oh, 100% they would affect movement. And that's the puzzle piece I mentioned earlier about it's not one specific. That's why we do such a thorough evaluation, and evaluations honestly aren't just on the first session. We see the body move over and over again, and then we start to put together patterns, and the patterns are really where that good information is at. So if someone has restrictions in their sigmoid colon, again, I'm just going to use that example again, in their left quadrant, lower quadrant of their abdomen, coming up into that pelvic sidewall, that connection fascially and viscerally is connected down into the pelvis. So you might see pelvic floor muscle tension on that same side. It's connected in a rotational pattern up to the other right rib cage. So now you might see that they can't twist their body. You might see that someone can't extend backwards, meaning stretch their body straight. So people get pulled forward, and they might not even realize how they've lost that range of motion. That's why we have to see someone move. And again, not see someone move one time, but move again and again. And then in terms of the manual techniques, so the hands-on techniques. So usually I would say most of my sessions have a component of hands-on work on the body, and that helps someone connect with the space that we're trying to think about moving and feel how that tissue feels for them, and then combine that with a home exercise that kind of directly relates to that space. Again, this is coursework that someone has to practice and take, hands-on training and clinical expertise on how to move organs. Takes a lot of repetitiveness. I always say organs, they have their own personalities in my world, just like how muscles have personalities, but small muscle groups, big muscle groups, they feel different. They respond differently. And so getting acclimated to what people feel after they have hands on their abdomen in a certain area and letting them know how their body might respond. Because it's so clear when you've, say, done squats that your quadricep muscles are going to be sore, your legs are going to be sore, your thighs are going to be sore. So when that happens, people aren't surprised. But when we are mobilizing, so my hands are on someone's stomach and moving connective tissue, they might have nausea, they might have discomfort, they might feel this, like I say, autonomic nervous system response. People can feel anxious, people can feel stressed by moving their organs and pressing on that connective tissue. And so you want to help someone understand what rehab for the organ motility feels like and looks like, so that they're not scared when they go home that they've done something wrong, because there's a lot of shifting in what I would call like their awareness of their body and really in that visceral system.
Oh, that's interesting. And so not only are you stimulating or moving the organs around a little bit, but you're also stimulating that nervous system. So that makes a lot of sense.
Yeah, the referred pain of that is really interesting. So, for example, again, localized musculoskeletal pain is familiar to people and they are not as distressed by it. But if I work on someone's gallbladder and liver and rib cage, that can go up to the right side of the neck. And so they got to know that information. They got to know that those things are connected. So they're not scared, surprised later when they're like, oh, I feel this thing here. Did anything go wrong?
And that's happening through the nervous system, right? Because I've had a few people in my work say that they feel a gas bubble in their shoulder because they're feeling the digestive systems in their shoulder. And we know it couldn't be a gas bubble like how we feel it in our intestines. So what they're feeling is actually the nerve. What did you call it? The redirected.
Yeah, the referred pain. So, kind of like how we know what a heart attack feels like and the variety of symptoms that can come up, because the heart might not hurt directly, but you got to know what that left sided feeling feels like. Or for women, you got to know that it might hurt in between their scapula.
Okay. Okay. Very interesting. So there is something that can be done about these adhesions. This visceral work can help to resolve, would you say, the adhesions in some cases?
You can influence connective tissue. I'll usually compare it to, I'll use my t shirt sometimes and pull it up into a knot. And I'll say, as everything healed from a surgery, everything went towards the knot to lay down, to protect itself. And we are slowly taking healthy tissue away from that space. So there still might be this underlying scar, right? But it's much smaller. And now it's not pooling on a whole bunch of healthy tissue around it that now can move really well. But this is why surgeons are like, well, we don't just want to keep going back in and doing another surgery, because removing adhesions creates other adhesions.
Yeah. Oh, that's such a helpful visual. Yeah, thank you for that. The knot in the t-shirt. So we're just pulling at it, making it smaller to help mobilize as much of that tissue as we can and reduce the effect of that knot.
Yeah, C-section is a really obvious way that people can see those connective tissue changes, because you're not going to get rid of a C-section scar, but you are going to help that scar have a lot of range of motion, and you're going to help all the tissue around the scar move better.
Okay, awesome. And then as far as pelvic floor work, so if somebody does have the dyssynergia, I guess, what are the steps somebody would go through if they're resonating with some of this and they're just thinking, but how would I get evaluated and what would treatment look like? Can you kind of give an overview?
Yes. So physical therapists have a doctorate in physical therapy, and by extension, we have direct access, I believe, in 48 states, which means that I don't need a physician referral for you to come in for an evaluation. I have enough differential diagnosis to tell you, oh, I need you to go see someone else first. But typically, I have people reach out on the website and we do a phone consult to make sure it's a good fit first, to make sure I don't need to send them somewhere else or to have a test first before they come in. And then really it's an easy process of coming in to schedule an evaluation. That's the fastest route. If someone is trying to use their network for insurance, then they would probably go to a physician, any physician that can do a referral process, and then they would request pelvic floor physical therapy. Here's the greatest thing. You can just have weakness, you can just have deconditioning, or you can report any of these pelvic floor symptoms, constipation, leaking, any type of pelvic pain, but it doesn't have to be a specific pain symptom. It can just be weakness. And so if someone isn't sure how to write a referral, all they have to do is say pelvic floor weakness. Because we're going to do our evaluation anyway, and we're going to determine what is happening.
Not sure what's wrong with you, just have the right weakness.
I mean, anything that allows you to get into the door. But more specific, I would say people report sexual dysfunction, a bladder symptom, or a bowel symptom.
Okay. And then do you tend to work with somebody, is it multiple visits? I would imagine it is. What does that kind of look like? Are they doing work at home as well?
Definitely. There's always stuff to do at home because I want someone to be able to feel confident managing things in their lifestyle and however they're living their life. And so I want whatever I give them to do at home to be sustainable, repeatable, consistent. I'm different maybe because I'm out of network. So our flexibility and scheduling, I would say my average patient comes in stacked a few times in the beginning. So we have some momentum going. So maybe once a week, maybe a couple times a week, but then we're quickly moving into, okay, now coming in every other week, every third week, so that there's enough time for the system to integrate these changes long term. And then the follow-up or continuation of that can be wherever they'd like to land. And they can also say, I'm going to take 3 months off. I'm doing pretty good. I'll come back in if I need it. Then they can drop back in 3 months later if they're trying to work on something new. So it depends on where they're trying to get to in terms of their quality of life, recreational activities. And then as constipation, SIBO, they go through these ebbs and flows. So I really want to be there for someone if they have a flare-up of symptoms. We do have discharge plans. And of course, someone graduates, they do great. But I like to think of the human body as constantly needing intermittent attention, where someone's doing great and they know how to manage this thing. But if you're living in a body, at some point, it might be a little disrupted again. And then again, that could be a quick little treatment blurb of 2 or 3 sessions to get you back on track.
So you said even though a flare is when you're going to tense up, that actually is a good time for you to work with somebody. Can you explain that a little bit more?
Mm-hmm. I think for a flare, the body wants to go back into protect mode, and we want that to be as short of a window as possible. So helping someone know what is safe to move into, what kind of sensation is safe to move into, is a large part of my job. Helping them understand the communication system. And that's no different than if they had a recurring disc injury in their back. When someone inevitably hurts their back again, if they're lifting and exercising and moving, the chances are they might have a disc injury again. And I want someone to get really good about their rehab process for that injury. And so I want someone to come in the middle of a flare so that we can help the system safely start to move and help with pain. And there's a lot of hands-on techniques and nervous system regulation that I usually say it doesn't completely eliminate pain, but it turns that dial switch down from a 7 to a 4. And that's a huge difference in quality of life.
Okay, awesome. Yeah, that makes a lot of sense. So where can people find you? You practice in Arizona, where I'm located, and that's where you can see patients, right? Because you're a physiotherapist. So tell us about your practice and how people can find you.
Yeah, my practice is Patton Pelvic Health. Patton is my last name. And it's so easy. You can go to that website and then sign up for a phone consultation. And it's great to talk through things, I think, to just make sure it's a good fit. So that's the easiest way to contact me. And those are in-clinic appointments. I do offer telehealth, but I really want to see someone first, at least for a visit in person.
Yeah, that definitely makes sense for what the work that you do versus our practice, which is coaching. We do it all over telehealth. And then when I talked with you before, you shared with me some resources since we do have clients in other states, some resources where people can find somebody in their area. So if you know those off the top of your head, you could share those now, but we'll also put them in the show notes because we share those with our clients now, the resources you gave us, and we might as well share them with the listeners.
Absolutely. A couple of websites. One is pelvicrehab.com, and those are all pelvic and I believe occupational physical therapists. And then I'm blanking, APTA, the American Physical Therapy Association, has a pelvic resource finder as well. And Pelvic Guru is another resource that has a variety of different types of clinicians that help with pelvic pain.
Okay, perfect. And will pelvic floor clinicians necessarily do the visceral work, or is that a separate thing to look for?
No, that's definitely something that someone has to take extra clinical coursework for. And you'd probably really want to talk to that resource office first and say, hey, do they specifically treat constipation? So, not every pelvic floor therapist, does internal exams. Not every pelvic floor therapist works with rectal pelvic floor dysfunction specifically, and not every pelvic floor therapist does visceral work. So, again, I think using free phone consultations that a lot of places offer is your best bet to save yourself time and energy. And I would do that if I could before I'd go into an office.
Okay, so for the issues we're talking about, the three things to ask about, can you list them again?
Yeah, absolutely. Internal pelvic floor physical therapy, specifically treating rectal conditions like rectal pain, constipation, dyssynergic rectal pelvic floor conditions, and then visceral organ mobilization is a separate training as well.
Okay, great. Well, this has been so helpful, and I just so appreciate your knowledge and your expertise.
Thank you for having me on, letting me talk about my favorite thing.
Yeah, definitely. Yeah, I just love it. You make it so easy to understand, and you've given us some really good visuals and analogies. So I really appreciate that.
Yeah, thank you for having me. It was great. And I'm happy to come back and talk more about connective tissue because I think that topic alone deserves a whole episode.
Yeah, okay. Well, we'll probably take you up on that. All right. Thanks so much.
Bye.